Next up, we'll be hearing from those on the front lines, mental health experts, providers, and caregivers. We have another number of questions for them. How can we ensure that the mental health system works for everyone who encounters it? And what can be done to make sure prisons and jails do not continue to be the primary providers of behavioral health care in the country? For a conversation covering these topics, I am pleased to welcome on stage John Snook, Executive Director of the Treatment Advocacy Center, a nonprofit that advocates for timely and effective treatment of severe mental illness. Dennis Hobb, Executive Director of the McClendon Center, a mental health crisis center that provides services to adults diagnosed with serious mental illness. Alpha Stewart, President-elect of the American Psychiatric Association. Fred Osher, Director of Health Services and Systems Policy at the Council of State Governments Justice Center, a nonprofit that provides research and analysis to Congress and state governments. And Teresa Pasquini, a mental health advocate. Teresa's son and brother both suffer from serious mental illness. The Hill staff writer, Peter Sullivan, will be leading this conversation. And Peter, I turn it over to you.
Great, thank you. And thanks again to everyone coming and our panelists. So figured we just dive right in with coming off the big news last night. The current Senate bill seems to not be going forward anymore. I want to kind of pivot off that and talk about, if that's not going to happen, I'm sure there's a lot on everyone's list, but what's one specific thing you'd like to see Congress kind of tackle with regards to mental health care if they're not doing this bill? We can have a few responses, but I don't know if someone wants to dive in to start us off.
Sure, I think there are a number of issues that I think are vitally important, especially to the mental health community, issues that still need to be addressed that we've touched on, but we haven't gotten there. We had a huge win with the 21st Century Cures Act, monumental reform, but we didn't get all the way. I think some of the biggest pieces that we have still in the queue, looking at HIPAA reform. Far too many families, far too many people with mental illness are trapped in situations where they don't get the care they need, they don't get the best possible care, simply because the law wasn't written with the realities of mental illness in mind. And so what we see is families not being able to find out where their loved one is, finding out if they're even in the hospital, finding out just the simplest things like what medication are they on, what side effects should I look for. I think members of Congress recognize that that is an issue that needs to be addressed. The other, I'm going to take a moment and add an extra, the IMD exclusion. I think we talked about it a little bit already during this panel. That's a real opportunity for reform that we need to take advantage of. I think there's a recognition that system is just broken. It's from the 60s, it doesn't make sense. That idea that we don't allow parity for inpatient mental health and substance abuse treatment is just outdated and wrong.
Anyone else want to jump in?
I would add, I'm looking forward to a bipartisan conversation on this matter, that there are some important gaps to close. There's the science to service gap, which exists with robust empirical literature about what works for whom, under what circumstances, yet when people walk through their common clinic doors, they often don't receive the state-of-the-art care. So we have to be thinking about promoting evidence-based practices, paying for what works, and ensuring that when you go and see a provider that you're getting the best care that science supports.
I think I would add, too, that while the legislation provided that mental health was an essential benefit, we're still lagging on the appropriation. Covering that, providing the funding for that still has to be established.
So maybe before we get more into what else needs to happen, we can look back a little at the 21st Century Cures bill that was passed last year that included a lot of mental health elements in it. So where do we kind of stand on that bill? Has it been implemented effectively so far? Are there big improvements that were made out of that, things that are still works in progress? How would you say that that bill kind of stands right now? Everyone wants to jump in.
Well, I'll jump in, particularly on the Safe Communities component of the bill. There were significant portions of that expanded care for veterans. We have over 20 veterans a day committing suicide, and we need to focus on those returning veterans and provide them the support and care that they need. Within the bill was a recognition of the importance of federal government in sponsoring innovation. And so while correctional administration is primarily a state and local phenomena, the feds have a role in promoting innovation in our communities, harnessing the information that's learned, translating that, and putting it back out. The bill also advanced treatment within the Second Chance Act for mental health needs, expanded the comprehensive community justice mental health collaboration program to ensure that throughout this continuum that law enforcement gets the training they need so they can stay on the streets and not in our emergency rooms, that the judiciary has education to allow for appropriate diversion. There's been within that bill an expansion and attention to what happens within jails and prisons themselves. I wanted to acknowledge Governor McAuliffe's emphasis on screening and assessment. If we don't know who comes through our jail doors, it's really difficult to provide them the appropriate services that they need. So I think there are a number of important, a $6 billion bill that really has advanced many of the issues that we care so much about and is in the process in various stages of implementation.
I'd like to add, so I'm the proud mom of an adult son with schizophrenia who was diagnosed at 16 and has, fallen through every crack of our system. And I sort of became an accidental advocate and activist and had the privilege of working with many families like mine across the nation on with Treatment Advocacy Center and with Congressman Tim Murphy. And in advancing the 21st Century Cures Act, the Helping Families in Mental Health Crisis Act. Families like mine, the families of the 4%, we're the 1 in 17, not the 1 in 5. We're the ones dealing with the most serious mental illnesses, the ones that I believe sort of, nobody wants to deal with. We don't focus on the 4%, we're dealing with the 96%. I thought for the first time, families like mine were brought into the forefront, and we were honored, and we were invited in to be partners in care. And so it was a privilege to be part of that. And I witnessed the 422-2 congressional vote and sobbed like a baby when that was over. But we're not there yet. We didn't get all we need. We have so much further to go. And so I'm delighted that we have more opportunities to work on bipartisan healthcare reform, and absolutely must start focusing on the 4% going forward.
Right. Well, maybe we'll go to John and whoever else wants to jump in on this one, but mentioning IMD exclusion, that was something that was pushed for in the bill last year, but sort of had to be scaled back in part because of the cost concerns. But there does seem to be some sort of bipartisan momentum for that. So where do we stand on that? Do people see momentum for that? Is that still kind of a top priority?
I think there is a growing recognition that the IMD exclusion has just outlived any purpose that it may have ever had. It causes too many tragedies every day. From every aspect of the system, it's just a relic of an outdated view of mental illness. And unfortunately, it's very stigmatizing. It's the only provision we have left in medical care that says, depending on the illness you have, we are going to restrict what kind of treatment you can get. So what happens is we have a situation where if you have a heart attack, obviously you can get intensive care. You can get ICU treatment. If you have a mental illness, if you have a substance abuse issue that you need inpatient care, you're told, no, the government won't help you there. And mental illness is like any other illness. Not everyone needs inpatient care, but sometimes people do. And to prevent that from being provided makes no sense. And I think as we see community after community just say, we're in crisis here, we need this solved, I think members of Congress are recognizing that and saying, we just need to do something. So I'm very heartened by the continued discussion, how many members of Congress know what IMD stands for. It's a wild world.
It's always a good first step, I guess. Anyone else want to jump in on kind of the effects, I guess, we would see out in the world if more people had access to beds? I guess it seems like that would be a important step in terms of just the caregiving perspective.
I'll jump in and say that I think we have a very incomplete system. My son, has fallen through every crack because we're dealing with a system of luck and heroics instead of a continuous system of care. And that, it's a chronic illness that must be treated like any other medical illness, which does mean that we can't solve this problem with only resourcing community mental health. That's very important. But we need to, I believe, marry the medical model and the recovery model, not divorce the two. Mm-hmm. So if we're going to bend the curve, and otherwise we will not be able to end the criminalization of mental illness. I mean, we will continue. The beds are in the jails. Mm-hmm. That's unacceptable. We have to stop that. So. Mm-hmm.
Maybe Dennis, bring you in when you're out kind of on the front lines of this. What are kind of is this a policy you think would make a big difference, or are there other things that you're thinking like I wish policymakers would take this up?
In the district, I don't think we really have such an issue with that. I think probably it's way too easy to get into the hospital here. What we'd like to do is keep more people out of the hospital and keep them from going back. I think anything that can be done to increase flexibility with funding and the way services are delivered makes that more possible.
Great. So maybe come back to Teresa and talk about another one of these big aspects of the bill last year was the HIPAA reforms that also still work to be done on that, definitely. Why is that such an important issue to help people understand who haven't dealt with that, and what are the kind of reforms going forward that you'd like to see in that area?
Sure. My son was diagnosed at 16. I'm also a sibling. I have a brother that was diagnosed with schizoaffective disorder 40 years ago, and was a success story, really. And so when our son started developing these symptoms, I'm like, oh, I know what that is, and we can handle this. We'll deal with this, and so he did get care immediately and was seen, and that worked from the age of 16 till the age of 18. But literally on his 18th birthday, he was involuntarily committed. And overnight, I learned that I had lost my rights as a mom to, even know where he is, even though I saw him placed in the ambulance and I knew which hospital he went to, and I called that hospital. I was told, nope, sorry, he's 18, and we can't tell you if he's here or anything else. But they certainly would call me to come and pick him up. And I was happy to do that, and we did do that until our son was 27 years old, off and on, even though there were over 50 hospitalizations. So the HIPAA hammer comes down, and it's killing people, actually, and it's destroying families. And it must be changed. And I unfortunately don't believe that we went far enough in the 21st Century Cures Act. I think we need to clarify it not only for families, but for providers as well. I think our providers also are being limited in talking to one another. Substance abuse can't talk to mental health. I mean, the silos are affected. Medical staff isn't speaking to psychiatric staff, even though I know we're doing a lot of integration. We're not there yet, and it's harming too many people.
I would like to add that even in its current form, HIPAA is used to shield providers from important communications with loved ones, and often misinterpreted. And I think we really need to start now in informing our provider networks about what the real limitations of HIPAA are, so that there are many circumstances in which information can be shared, should be shared, that doesn't get shared. And these can end up with critical missed opportunities, poor management of that individual when they need the care the most. I think that within the Cures Act, the push for exercising professional judgment and engaging families, obviously respecting the rights of consumers for their own need to protect information, but allowing professional judgment to enter into this to have essential conversations about the nature of care, what's worked in the past, what hasn't. This is just common sense. And I think far too often HIPAA is used as a barrier to this common practice.
I also think that that's something that we need to do a lot more training with our frontline staff on. I agree sometimes they use it as a shield. They don't fully understand what they can share and what they can't share. I was telling one of our panelists earlier, we had a father who called us to say, I know where my daughter is, you're trying to find her, but I can help you find her. And the staff were reluctant to use his help because they didn't want to release the fact that she was client. But he already knew that. So I think that sometimes we haven't done the right kind of training to help people know that, this is not a barrier. It's supposed to protect someone's privacy but not prevent their treatment.
I think, though, that all of this sort of circles around the central issue that came up earlier around stigma related to mental illness. No other part of medicine has these very complicated issues built into just trying to provide treatment. And we've got to do some work. Neither the ACA and the mental health parity or 21st Century Cures went far enough in the understanding of the significance of, if we don't deal with the stigma and discrimination related to mental illness, we'll be less likely to be successful in work to treat mental illness effectively.
And this kind of goes off the stigma point, I think, is something we discussed earlier, was in terms of media attention. Sometimes there's a whole burst when there's some national incident, a shooting or something like that, and then it sort of fades away, and there's a cycle of like this. So this is broader than just talking about policy now, but how do people view keeping up attention on this issue maybe in a more healthy way, in a more sustained way around mental health as a broader issue rather than just kind of bursts of attention when there is some sort of incident? Dr. Stewart, you mentioned that.
I think I would say I would love to see the media begin to look at this from a multi-pronged approach. Yes, attention needs to be given when there are incidents that significantly are newsworthy, that also include some mental health aspects, but we don't hear enough about successful treatment programs. We don't hear enough about how complications like HIPAA or IMD exclusion make the situation more difficult, and how the public in general should be more educated, better educated around these things, and be able to then help push the needle on getting some movement in these areas. I also think, if it bleeds, it leads. When it comes to mental health issues, really is very detrimental, not only to making the case for good mental health and good mental health treatment, but also in giving the general public the sense that mentally ill people are dangerous and violent and to be left alone. These are family members of someone. These are people who are part of communities that care about them. And when they're stigmatized and discriminated and painted with this broad brush, people begin to stay away from them. I work with children who are at risk for going into the juvenile justice system who have mental health problems, who've been seriously traumatized. These are families that are now isolated from their own family unit because they're described as bad kids. No one wants to be around them. Imagine not being able to go to the family reunion or the holiday dinner or grandma's 99th birthday or something because your child isn't welcome. We have got to, as a society, do better.
And I think we're moving to a point where we can have a more nuanced and capable discussion of the realities of mental illness. I think there is a tendency to avoid the conversations around violence as stigmatizing. And that, at the end of the day, that doesn't help anyone, because those situations happen and people know when you're not being honest and talking about trying to hide something that is out there. But the reality is, and the way we're able to talk about it now, because everyone is more educated, we can talk about the fact that every one of those incidents that make the news are combined with 100 incidents that you'll never hear about of a young man who's trapped at home because he can't get a job, of people, women with mental illness who are arrested, left in jails for months because they can't make bail, and then act out in the jail because of symptoms of their illness, and eventually are released 180 days later. And again, no crime, but simply symptoms of a mental illness. All of those discussions can happen now because we've moved forward. But I think we do a disservice to act like those incidents don't happen. I think the reality we have to say is we need to stop allowing people to get so sick and to base our treatment on, well, is he dangerous yet? No, well, then we're not going to provide treatment. Virginia saw that for years and hopefully is moving away from that standard. But far too many communities say, there's nothing we can do until he tries to hurt you or tries to hurt someone else. And that reality we need to get past, and then we can have broader discussions.
And maybe bring in Fred Osher in terms of the kind of criminal justice element of this. I mean, what are some ways, I guess, we can cut down on just having jails be the provider here? Are there particular programs you've seen that have been effective in certain areas? I mean, what's kind of the steps we need to take in that area?
Yeah, I think all of us are horrified by the criminalization of mental illness that occurs. We are applying a 19th century approach to 21st century problems, and it just needs to stop. It's a tragedy that breaks everyone's heart who is close and familiar to it. We'll have over 2 million adults this year with serious mental illness booked into one of your county jails around this country, 3 to 6 times the prevalence rate of mental illness in the general population. To the stigma issue, most violence in this country are not done by people that have mental illness. Most people with mental illness do not commit violent crimes. There is a role for diversion where we can allow individuals with mental illness that have committed nonviolent crimes that don't pose a public safety threat to find alternatives to incarceration. Little periods of time in jail, 2 or 3 days, mess up your life. Separate you from your job so you don't get a paycheck and you can't pay your rent, and you end up on the street. It just isn't a place for individuals that need care and treatment. So what we've seen throughout the country, and again, sponsored a lot by some of the federal funds that have allowed for innovation, starting at the front end with law enforcement, police mental health collaborations, helping officers understand, recognize, and approach in a way that de-escalates the situation and provide them alternatives to incarceration. We've seen training of the judiciary, the establishment of mental health courts that allow, again, for diversion of appropriate individuals back into the community, out of the jail settings. We've seen jails around the country step up. There's a Stepping Up initiative that National Association of Counties, American Psychiatric Association Foundation, and the Justice Center have supported. Almost 400 counties have passed resolutions that say the status quo is not acceptable, and we're looking for structural and systemic reforms that reduce the prevalence of people with mental illness entering our jails. Importantly, at the back end, making sure that individuals that have identified with mental health needs get connected to the treatment and supports in the community that they need. And then I think probably to the core of the focus of our discussion today is there needs to be a robust mental health system. We have to have a way to serve people when they need it, where they want it, how, with the services that are appropriate, so that we can create and prevent the likelihood of contact with criminal justice entities going forward. We have dug a hole with funding for mental health services that have not nearly been adequate to the demand and the need. We need to fill that hole in significant ways so that we can start to design communities that are safe for all of us and that allow those individuals with mental health needs to get them addressed in a preventive way, in a upfront way. We've talked a lot about spending money at the front end so you don't spend so much at the back end, and that can't be more true for the criminal justice mental health nexus.
I thought maybe before we get into audience questions in a minute, maybe we just end with some maybe local ideas or at least small scale, not as well known ideas in terms of initiatives or programs that maybe if people are looking for ideas they can take up. These might be good sort of pilot projects or small ideas. I don't know if in DC, Dennis, if we've seen anything in particular that you think other areas should be trying this, or some sort of good idea on a small scale that you think is effective.
I'm glad you asked me about that, because we're doing a couple of those things at our agency. One of those is a program called Post-Emergency Evaluation Services. If someone's covered under a certain health plan and they've been admitted to the emergency room for a mental health reason, then we find them within a week and then get them connected to treatment. There's a lot of coordination that has to happen to make sure that we get notified in time to do that. But so far, we have found a number of people and gotten them into treatment, and they've been really high users of emergency care, and this has stopped that. It's relatively new, so we're not sure what this is going to be like over the long haul, but that's pretty promising. So I think the health plans putting the money up front to do that really saves them on the back end, and it gets the people that we're finding the treatment that they need.
Great. Anyone else have programs or ideas they want to plug before we get into?
I know we haven't touched on the opioid crisis, but I'm based in Memphis, Tennessee, and in our Center for Addiction Medicine, the director has decided that everyone who comes in for treatment gets an assessment for their level of trauma. You know, the exposure to trauma early in childhood, we know, creates an environment where the child develops and is more likely to, as they grow into adulthood, have some challenges around mental illness, substance abuse, chronic medical problems. And so everyone who comes into his service now is assessed through an ACE questionnaire, Adverse Childhood Experiences. And he's determined over the 1,700 or so of these that he's done, that in 99% of the cases, we can look at the development of their substance abuse problem and relate it back to an early childhood experience. So we're looking at ways to incorporate more trauma-informed care at the front end, looking at it as a preventative measure. And since I work with children, we're incorporating that into the children's mental health assessment.
Great. Teresa?
I just wanted to share that, yes, I am a founder of a partnership that was founded at our local community hospital, Contra Costa Regional Medical Center in Contra Costa County. And I want to do a shout out to the front line working on the psych unit there. And I was invited in. I call myself a recovering angry mom because I was, before I was invited into this partnership, and I was angry. I was mad at the system. I didn't know what was going on behind their door. They didn't know what was going on behind mine, but they invited in and we created an authentic partnership. I actually sit as a volunteer family member on the executive leadership team of our county hospital. And have been privileged to be on the front line and working to make healthcare more welcoming and accessible to all in our county. So I encourage all healthcare providers to invite angry moms into the room because we'll help you redesign your systems.
Great. Well, I think we had about 5 minutes for audience questions, so there are mics coming around if anyone has a question. There in the third row.
The federal government has really seemed to embrace assisted outpatient treatment with pilot programs and a series of trainings. How do you see this playing out, especially for communities that don't currently have AOT? And in relation to that, too, I'm wondering if any of you know whether there will be any more new grants being given to new communities that don't already have a grant.
So that would have been the program that I would have referenced in the exciting things, because we're seeing some really exciting stuff on the ground with those federal AOT grants. The first round is out and running in communities all across the country. We're seeing some really good responses, and I'm very excited because it really pulls in what Fred was saying, that idea of diverting people before they end up in the jail system, before we end up in those worst case scenarios. So you're providing people care without having to get arrested first. Excited to say that the Labor HHS Committee included it with full funding for another round, so we assume good things moving forward, lots of good data on the effects, so sky's the limit.
Right. Other questions? Over there?
There seems to be general agreement among the panelists here and the earlier speakers that we need evidence-based, access to evidence-based treatment in a system of care. There's agreement upon that. But I would like to know are there any lobbyists? Who's lobbying for that? Who in Congress is advocating parity? We don't have parity in Medicaid, and unless some states choose to do that, but it's not mandated. So where are the advocates for that? Is there any chance of progress in that direction? Who's going to introduce that?
So, you go ahead.
Well, the American Psychiatric Association is part of a coalition of mental health related organizations that are continually on the Hill, speaking with legislators, helping to educate them about the importance of full implementation of the parity bill that is the law. Part of that has to do with the slowness of people coming to understand what full parity means, apparently. When you say full parity, you think that everyone understands it, but very clearly there is a segmented understanding of what full means. So we will continue on behalf of certainly our membership and the people that we serve for mental health needs. We're going to continue to advocate for implementation of full parity in the legislation that exists. We're going to use those opportunities for the components that are part of 21st Century Cures around coordination and coalescing of these kinds of coalitions to work together better and to develop the kind of workforce that's needed to actually be there to provide those services in a fully implemented system of parity.
And I think it touches on a vital point for this crowd and for the community at large. There is a risk that members of Congress, the general public, will say, I think we addressed mental health last year, and we're done. And I think the reality is that you all need to keep doing this work. There's never been a time to be more optimistic about the opportunities for reform for mental health. People get it. People get that we're in a crisis, but people have a limited attention span, so we need to keep that attention up. And the more that you all engage, the fact we have a full room here, all the people who are listening today, that's an opportunity that we need to keep taking advantage of.
Hi, thank you for taking my question. My name's Janet Hayes. I am from New Orleans, Louisiana, probably the state's #1 incarceration place in the world. And so in my parish, in Orleans, I'm wondering how we shift dollars back from the corrections department to the health department. Just as an example, my parish right now is investing $2 million in a low barrier homeless shelter and talking about an $85 million mental health jail as part of a jail expansion. Do you all have any suggestions or ideas about how we can shift corrections dollars back to health and human services, or, in Louisiana, be Department of Health and Hospitals, but any ideas would be most welcome.
So it's a great question, and that we have great examples of that happening around this country. Justice Reinvestment as an initiative, and the sheriffs don't want to be the largest houser of people with mental illness in their communities. Correction administrators are at the table saying, please help us with individuals that are in our jails and prisons that have significant mental health needs. And that I think the key has been collaboration. None of this occurred through one system's failings. It's been the failings of a number of systems, and the solutions will come through that collaboration and consensus. And that I do believe that the ability of counties who are paying $80 billion in health in criminal justice costs to look across the spectrum and see that dollars spent here may not provide the return on investment that dollars spent on a housing program could. And we need to present the data, as we've been talking about throughout this morning, about how spending at the front end creates savings at the back end. So I think justice reinvestment is a real notion that has bipartisan support. I would add, that really is a critical element to grab hold of at this time. Republicans and Democrats appreciate that money is being wasted and there is just scarce resources that we can't afford to do that with, are coming together for common solutions to address the problem that you have highlighted.
Great. Well, I think we're actually out of time, unfortunately, but thanks for the questions, and thanks to all our panelists.